All right. Let's finish it up. A bit more to do with the women and then straight into the men. All right. Let's see. Oh, yeah, birth control. That's where we left off. The first lesson they want you to know about birth control, remember before I said, never tell a woman what she ought to do. You advise her. And the question they say you ought to ask is just, have you thought about family planning in the next 5 years? That means it's wide open, it's non-judgmental, there's no confrontational. Let her then tell you, yeah, I plan to have children in the next 2 years. Okay, then we don't have to worry about birth control. But if she says, well, I don't plan on having children for the next 5, 10 years. Okay, well, have you thought about birth control? And then she will tell you what she's thought about. And most women will start with whatever their friends have been using, okay? But, let's say she says, well, my friends are on pills. I thought about that. You say, well, have you thought about longer acting methods, which means you can take it for 5 years and not have to think about taking it every morning. So that way, notice there's always have you. That way you're causing more discussion. You're not telling her what to do. You just have you thought about this. Like I said, the LARCs, long acting, are way more protective than the short acting. And it turns out most women don't take it the right way anyway. They forget. They're going away for the weekend. They forgot their pills at home. That's 2 days they're going to miss a pill now. All right. And that comes as a problem. They're always calling you. Oh, I forgot this. And then you got to know how to respond to that. Okay. All right. So that's an issue. Next issue. How do you start? Before it was, you start her on pills and she would start on the Sunday following her next menses. So if her next menses was on a Tuesday, she would start that Sunday. Any day before that Sunday, she would just start on that Sunday. That because it was a day that people could remember after church or before church, that kind of thing. Then they did a study called Quick Start, meaning what if we just start birth control the same day you come to see me? Would it be just as protective? And the answer was yes. It was the exact same protection. So now Quick Start is the standard care. You start birth control the same day the woman comes to see you. Everybody with me so far? So now the next issue is what do we do before we start the birth control? Okay. Again, we're pushing towards the LARCs, but if she wants a short act, that's up to her. But there's things you got to do. Number one is always a pregnancy test. You don't start any kind of birth control and then you find out she's pregnant. And now if anything happens, she's going to blame you for it. So you must do a pregnancy test before you start any of it. Number two, you rule out STIs, especially in young women or any woman with risk factors, meaning if you changed men in the last 2 men in the last 6 months or 3 in the last year, then we're going to check you. Okay. So check for STIs. And now remember with the NAT test is easily done. She can go in the bathroom and do it herself. 1 drop of urine, bring it back. That's it. Okay. And because she's a patient of yours, you know she's going to come back and find out the results, or she's definitely going to call you and find out the results. All right. If any concern, treat her right then and there. If not, don't treat. Wait till you get the results. Remember, now you only treat what the culture tells you. Only cover chlamydia if chlamydia is there. Only cover gonorrhea if gonorrhea is there. We don't have where you have to cross cover anymore. The NAT test is that specific and that sensitive that we trust whatever it says is positive. Any questions so far? All right. Then you want to get a history. Have you had any history of blood clots? Then we can't use hormones. Okay. Do you have any unresolved bleeding that you haven't told me about? Then we can't start birth control yet. Anybody follow? All these things got to make sense to you for you to remember it. If you just memorize that list, it won't make any sense. You won't remember it tomorrow. Okay. So those are things that concern me if I'm the physician. And I say, okay, I don't want to start hormones and then cloud the issue and then I miss something like cancer. Okay. And then you're in big trouble. So once everything is cleared up, you start whatever birth control she wants. All right. The IUDs, the progesterone IUDs, all of them last 5 years. That's why they said long acting, 5 years. Nexplanon and Norplant, those are usually 5 years as well. The copper IUD, 10 to 12 years. All it does is cause a little gentle inflammation around the cervix, and it kills over 99% of sperm. Okay, but it doesn't cause any bad things that people were worried about, like infections, STI, UTIs, ectopics, abortions, doesn't cause any of that. You got 30 years of research in Europe, and it has not shown any of the bad things that people were worried about. Okay. All right. Any questions so far? Yes. Yeah. I mean, so you're saying, so he was asking if you have obesity, so beyond, I think 50, BMI of 50 or greater, and some of them are BMI of 25 or greater. No, that can't be it. It's got to be 50. Yeah, so 50 or greater, you can't use their pill because the dosing is based on you're under 50 BMI. All right, so that means you try something else. Okay, that means you want to use copper IUD. This way you don't have to worry about hormones at all. Okay, because if they're over that, the manufacturer's BMI peak, you cannot use that pill because that means that dose of progesterone is not going to be enough for that person to stop the pregnancy. That means if she gets pregnant, she's going to turn around and blame it on you. It's called a wrongful life lawsuit. You made me bring in a life that I really didn't want. Man, people always find a way to blame somebody else for everything. All right. But anyway, just so you know, that's why they're going to test you on it. All right. So what about the pills? Here's how you start the pills. You start the pill just like anything else, quick start. And you say, okay, take one pill every morning at the same time. You should do it around an activity that you do every morning. So that means if a female, there's a special merit where she goes to comb her hair and put on her makeup, have the pill sitting right there. That way, as soon as she shows up to put on her makeup, do her hair, wham, she knows, take my pill. Okay? Because otherwise, if they just keep it in their purse, guess what? Some mornings they're going to forget. So you have to advise this to them so that they remember, okay, let me see, where am I going to put it? Oh, yeah, where I put my makeup on. Or where I put my keys, because I can't leave in the morning without my keys. That way she knows, take your pill before you leave the house. It's better take it at the same time every day. Because remember, circadian rhythms are based on a 24-hour cycle. So if the brain sees a hormone comes in every 7 o'clock in the morning, guess what? It sets a 24-hour cycle based on that. And therefore now everything is completely suppressed the way you want it. If they jump around, you might confuse your pineal gland. If the pineal gland, like jet lag, gets confused, it shuts down for 2 to 3 days. That means you can get pregnant in those 2 to 3 days. That's why you don't want the pineal gland confused. And when they did research on teenagers, these were young girls, and found out, well, how do you take your pill? Man, they found out 9 out of 10 don't even know how to take their pills correctly. But it fell back on the physician. Because the next question was, did your doctor review with you how you ought to take your pill? Nope. He just gave me the pills. They take one every day. See? Now, I'm not sure why doctors don't do that, but you should. There's a code for educating people. Doctors always complain, oh, I don't get paid for that. Yes, you do. The problem is most physicians have never studied the code book. I mean, I had to learn all this on my own because there's no class for it. I mean, now they got classes because they're showing that doctors, they had cases where doctors can double their salary just by using a code that they didn't even know even existed. I went through and I happened to find one because I love teaching, obviously. So I found codes like for asthmatics. I was interested in asthma, how to keep them stable. And there was a code for educating in asthma. All I got to do is ask one question. How is your use of inhalers? That's it. And that means in my chart, I said, ask the patient about inhaler. That's it. That's like an extra $15 for 2 seconds of writing. Multiply that, that's how many asthmatics you see every month. That's a ton of money. So when doctors whine and cry, folks, it's because most doctors are bad businessmen. They don't take the time to do the stuff they ought to do in order to get the reimbursement. The codes are there, but it's not like they're going to come and tell you, hey, doc, you're not charging us enough. No, that's your business. And that's why people are making money now just coding for doctors. See, but you're paying them, whatever, 10, 20,000 to recoup 100,000 for you. So they're making a ton of money now because doctors just are pretty lazy about coding. So folks, there's coding for education. So please, when you get out there, just look it up. That way you make a commitment. That means when it comes to birth control, make a separate office visit where all we're going to do is talk about birth control. Don't kind of mention it as he's going out the door for something else that she came in for. This is something you have to sit her down and let's discuss all the things you need to do. Take it at the same time. Make it around something that you do faithfully every day. Okay. Any questions on that? All right. So now, what if she calls you? So, okay, let me just say, how do I start it? So I say, Miss Smith. All right. I turn to the page in the PDR. You see all kinds of pretty colors, but there's a science that they're going to test you on. And that means you start with the lowest dose of progesterone that suppresses LH. It's like 600 milligrams or microgram. I don't know if it's micro or milli, but 600 is the number. So I just turn to that page and it gives me about 100 pills. Take your pick. They always say, get familiar with one pill in each category so that you know, just keep using the same ones. Okay. So for me, I always remember lowest dose. So the lowest in his name, just reminded me, or a Demulan. Okay. So I said, Miss Smith, take one of these pills every morning. Then every pack, there's 21 pills that are real. Then there's 7 pills that are just, powder. Why? Just so she has something to take every morning. Because if you say, well, then 7 days later, take another, forget it. She's going to forget. So that's why a pill every day till the pack is done. Everybody understand? If everything goes right, she'll take those pills. And I say, well, call me back in a month and tell me what happened. Notice I don't tell her what to report on because you want an honest report. If you say, well, I want to know about weight gain, that's all she's going to report on. Yeah, I gained weight or I didn't gain weight. That's it. You don't get the whole picture. Let's say, come back in a month or call me back in a month and tell me what happened. That way you get a full report, okay? Now, if you actually blocked her ovulation, then Mancy should drop by 90%. So let's say she says, I bleed for 6 days. That's her baseline. I give her a pill. She takes it every day. Remember, until I tell her she's protected, she's supposed to stay on condoms. Make sure you use condoms with her husband or boyfriend. Till I tell you you're protected by those pills, you're not protected yet, okay? Because some of them think as soon as they start the pill, they're protected. No, you're not. It may take me 2 or 3 months to get it right. But that's what you're supposed to tell them. Until I tell you, use condoms. Okay, so she calls me back in a month and says, I normally be there 6 days. This time I only spot it for 1 day. I said, oh, good. I cut it down by 90%. That's the right dose. And the articles say now, write prescription for 1 year. Writing prescription for 1 month. Then she got to remember to call you by the end of every month for another month. They said, don't do that. Give her 1 year's worth. Once you get the right dose, 1 year at a time. Okay. It just cuts down on the forgetting. That's if I got it right on the first time. Second scenario. She calls me back in a month. She said, I know it'll be for 6 days. I bled for 5 days and spotted on the 6th day. Did I block it? How's it? No, that's not 90%. Maybe 5%. That's about it. So I said, okay, that's not enough. That means I need to do what? Give her more what? I said, no, we're working with progesterone. Progesterone blocks ovulation, not estrogen. That's why you just turn the next page. There's the next higher dose of progesterone. Take your pick. Just a lot of pretty colors, folks. But it's the science that they will be asking you about on the exam. What is the next step in your management? I mean, you got to understand what this woman just told you and know that she needs more progesterone in her pills. That's it. Just increase progesterone in the pill. They don't even want you to know the names of the pills. Just increase progesterone dose. Okay? Because there's so many of them on the market. Start off with the lowest dose of progesterone, correct? No, 1 month follow-up every time until you get the right dose. Because she's not going to know if it worked right till the end of the month. And then she can tell me, did you see a bleed for 6 days or bleed for 1 day? Then she can tell you. All right. So the first scenario, you got it right on the first try. Give her a year's worth, see you back in a year. All right. But remember, you always tell her, call me anytime if you have questions. Second scenario, I didn't get it right. She needs more progesterone. Just increase the progesterone dose. Third scenario, she only spotted for 1 day rather than bled for 6 days. Lynn, did I block her ovulation? Yeah, I blocked it. But she says, Doc, I'm uncomfortable with that. Now, who would ever tell you that they're uncomfortable with making the period go away? Older women don't like it. Why? Older women equate normal vaginal blood flow every month with normal femininity. They don't feel right. If they don't see blood every month, it doesn't make, they don't feel good as a woman. I'm serious. They will tell you, Doc, I don't like this. What do? You add a little bit of estrogen in it. That means it builds a little bit of layer that sloughs off at the end of the month. Now they're happy. But at least they're spotting a little bit, not because they're ovulating, but because I created a little lining for them. That's it. That's the third scenario. Any questions on that? Okay. Next scenario. She calls me and she says, hey, I forgot a dose yesterday. Man, what should I do now? Double up today. Continue. You're good. It takes 3 days to release the HPO axis. So if she misses 1 day, double up the next day and continue. She misses 2 days. That's a weekend getaway. You know, a sleepover for teenage girls, and they forgot to take their pills with them. You tell them double up for 2 days then. Double up on Monday, double up on Tuesday, continue back. You're good. But once they miss 3 days, that month is released. Anybody who misses 3 days, that pack is no good. You tell them throw away the pack, use condoms. We're going to start over when you start menses again. And we keep going till we got it right. Any questions? Those are scenarios they're going to test you on. What are you going to do? And you got to know how to respond. All right. That's the pills. All right. Obviously, the IUDs are better because you put them in and you don't have to worry about for 5 years. 5 years. Copper, 10 to 12 years before you even have to worry about it. And that's why they're so much better because there's no forgetting anything. All right, Anders. First day you see them. No, now Quick Start says see you. First day they see you, they can start the pill. Yes, it worked just as well as starting on that Sunday after your period begins. We don't do that anymore. Any questions on birth control? Karis? If you're on the long acting, the LARCs, if you're on the LARCs, long acting, are you ovulating? If you're not, then what proliferation is going on? Good question. When we started birth control in women, way back whenever, all right, it was progesterone only. All right. If you have a doctor who argues with you and say, no, it's the estrogen in there. You say, okay, not what I do. You know, again, for what I understand, well, I really don't understand. You got to break them down right here. All right. So you say, listen, if one were to think that estrogen is the one that actually stops you from ovulating, how many estrogen only birth control pills can you name? 0. There aren't any. That's how you shut it down. So the doctor who's arguing with it has never even thought about it. How come there's no estrogen only if that's the one that's stopping me from getting pregnant? No, it's a progesterone. There's a ton of progesterone only everywhere. That's because progesterone is the one that actually stops you from getting pregnant because it blocks LH. The surge, without the surge, there's no ovulation. Everybody clear? All right. The problem is if I give you progesterone only, which we do, I'm going to feedback inhibit your LH, but I'm also going to feedback inhibit your GnRH. That means I'm going to shut off your whole cycle. Everybody understand that physio? Feedback inhibition is the rule. Doesn't matter if you never read it before. That's the rule. That means if I shut down your whole cycle, for a woman, that's not good. Why? She needs estrogen for coronary artery disease protection. Remember, vasodilation. Muscle light keeps her blood pressure low. It raises her HDL. Do you really want to take that away from her? No. So that means if I'm not thinking about it and I just start it non-discriminately, guess what? You put her in a medical menopause, and now before you know it, she's dying from a heart attack, and then the parents turn around and sue you for it. Okay? So that's why they said, okay, what are we going to do? Second, a female needs her estrogen to protect her from osteoporosis. You don't want to take that protection away from her. So they say, you know what? Let's add estrogen to birth control pills. Estrogen in OCPs, folks, was an afterthought. It was never in there in the beginning. They said, because she needs it. So then they added 150 micrograms of estrogen to birth control pills. And then they started to do the research around the country and around the world and say, how much estrogen does an ovary put out in the average female? When they finished the studies, it was 30 micrograms. And here they were giving everybody 150 micrograms. Everybody see that? That was those old birth control pills that was associated with breast cancer and endometrial cancer. We were overdosing women back then. Today's pill starts out with 30 micrograms, exactly the dose that we put out every day. And 2 big studies, one in Europe, one here, with almost like 400,000 women. So I mean, the power is just that strong. It showed no increased risk of breast cancer or endometrial cancer if you use today's pills. So now I see these questions where a woman found on the internet that, yes, this caused breast cancer, and she's now asking him, hey, doc, what do I do with my birth control pills? That means if you don't know how to discuss it, guess what? She's going to stop the pills now. So that means you got to know how to put up the argument that was the old pills where they put in too much estrogen because they weren't sure what the right dose was. Now we're dealing with new pills that have the exact dose that your ovary would have put out every day. So that way you get the protection you normally need, but the birth control pill works. Okay. So that's how they came up with that. today's pills don't promote breast cancer or endometrial cancer, but here's the caveat. They say, if the woman has a family history of breast cancer, or she has a previous history of breast cancer or endometrial cancer, don't use hormonal. Why? Because you're just inviting a lawsuit. It's not that you're going to lose, but it costs money to fight these lawsuits. Because that means if she comes down with breast cancer again, she's going to blame you now. So that's why they say in those instances, just avoid it. Just avoid it, because now it's going to create a huge problem. That's a big legal issue. So don't use it, especially since we got so many other things they can do now. All right, Michael. No. It just says if you have a history of breast cancer in the family, or you have a previous history of breast cancer or endometrial cancer, we're not going to use hormones. Yeah, because we don't want to take the chance. Yeah, it's for the lawyers. I mean, the lawyers will find a way to sue you anyway and say it's still your fault. That's why ACOG said just don't do it. Yeah, it's not even worth it. Yes. Depo-Provera, no, Depo-Provera, is his question, is a once every 3 months progesterone injection. I mean, with that one, you can't do a quick start because it's supposed to come back every 3 months. That means I got to give you something today. That means unless I want to just start the pill today, come back in 3 months, and I give you a Depo-Provera, or I've never seen that one be part of quick start as far as injections. Yeah, so I've never seen quick start for a Depo-Provera, so I would use the old recommendations. Huh? Quick start is for the pills, correct. Where I am.
Excuse me, doctor.
Wait a minute, hang on. What's your question? Okay. No, they don't. But what I was leading up to is that if I give you a progesterone only, folks, a lot of that progesterone will get converted to estrogen. Remember, you got aromatase doesn't do that for you. All right, so that's why they tell you every hormonal contraceptive has the same thromboembolic risk. All of them do. However, that risk is 1 to 3%. Didn't I tell you 1 to 3% is acceptable? That's why we don't worry about it. Okay. Well, it's different. I'm getting to that. They have a different formula. Yes. Yeah. Depo-Provera can be used as chemical castration because all you're doing is inhibiting everything. You're shutting down everything. And so that's the same thing as just taking away all hormones from this person. All right, Leslie, you had a question.
Yes, I have a question regarding, like you said, that any person with a family history of ovarian, breast, and endometrial,
not ovarian, breast and endometrial.
Breast and endometrial. And the second question is about, like you said, after she missed the third pill, you have to let that she bleed, right? She bleed.
Yeah, and right. That means let the pack go.
When she stopped bleeding, that's when she have to begin the pill again with another packet?
No, you can start with the next time she starts bleeding. That means they used to say the Sunday after she starts bleeding. But now you can just start once, because remember, once you start bleeding, you're in day 1 of the next cycle. Yeah, okay, we don't wait for Sunday anymore.
If the patient, is because I have always confused, if the patient like suddenly stop 3 days of the pill and then she begin 3 days after bleeding, she can begin the pills 3 days after stopping with the new package?
Yeah, exactly. Just whenever she starts the next period, you start again.
Okay, so the bleeding is not because the estrogen is increasing, the physiologic estrogen.
No, she's bleeding because her cycle got released. The HPO axis went back to normal. And that means when she starts bleeding again, that means she's starting another cycle.
But it's not like she's menstruating.
No, she is menstruating because she released the whole, you had a hold on it with the hormones. Once you stop the hormones for 3 days, you just released the hold. That means she can go right back to menstruation. And that's why they say, wait till she menstruates again. Once she starts menstruating, start another pack of pills.
Oh, because I got that confused because sometimes like OB/GYN doctors say that you can have bleeding with OCPs.
Sure you can.
So like a side effect, like not like you begin to bleed because you get the menstruation back.
Right. Let me just talk about that. That's something different. Can you have bleeding while you're on OCPs? The answer is yes. Or IUDs. The answer is yes. But it's not because you're menstruating. It's simply because the progesterone, if it's progesterone that you're taking, gets aromatized to estrogen, and that stimulates the endometrium some. So you get a little bit of bleeding at the end of the month, but not because you ovulated. Okay.
Thanks.
And then the pills, we now put estrogen in. Even at 30 micrograms in there is going to build a little bit of wall, and that's going to slough up at the end of the month. But you're just spotting, but not because you're ovulating. It's because of my medication. And that's why we say that's not a problem. Okay. Okay. Next topic, menopause. What is menopause? When your ovary says, I'm done working. I love you, but I can't do this anymore. All right. I can't give you any more estrogen. So menopause is normal ovarian failure. That means if it happens early, we say premature ovarian failure. When would that happen? In a woman who had radiation or chemo or cancer? Well, that's it. The ovary will shut down. Okay. So that's menopause. Second thing, do not call it a disease. Menopause is a normal process. You know, companies love to call everything a disease. That means they got to treat it. You don't have to treat menopause. All right. If the female can handle what's going on, leave her alone. But I just want you guys to know the definition of it. Next thing, how do you know somebody's in menopause? If the ovary stop working, the best test, remember, is a signal to the ovary. That's called FSH. So to ask you what hormone would you check, it's FSH. Okay. And average age of menopause in America is age 50. And FSH of 50 equals menopause. So easy to remember, 50 at 50. What the heck is a hot flash? Because that's the hallmark of menopause, right? What's a hot flash? A hot flash, Maria, is your ovary says, Maria, I miss you so much. You know what? I'm going to give you a big surge of estrogen. You're like, wait, when are you going to give me a surge of estrogen? No, I love you. I'm going to give you some estrogen. You say, no, don't give me no estrogen. I haven't seen estrogen in 18 months. You give me estrogen right now. All my receptors are upregulated. Everybody see the problem? When that estrogen comes out of the ovary, all the receptors are upregulated. You whoosh, sudden surge of estrogen, vasodilation, all the blood flow goes to your skin, which means all the heat goes to your skin, and then you perspire heavily to cool yourself back off. That's what a hot flash is. Just a sudden surge of estrogen, and because all the estrogen receptors are upregulated, you get a super normal response. Okay? And of course, that creates so much anxiety for the female who's going through it. Because if it happens at work, all of a sudden she got to go change her blouse because she's all blouse is soaked. Okay, and people around you may not know what's going on. Yes, Solange. Okay. No, she's asking if those moments happen long enough for you to develop dramas. The answer is no. It's such a sudden pulse. Yeah, just a few minutes. All right. That's what a hot flash is. Okay. So that means you teach the parent, or the woman, what a hot flash really is. It's nothing to worry about, even though it's causing her anxiety. So the rule is, this is updated from the female who's the national expert on menopause. Number one, she said, if the female can handle menopausal symptoms, do nothing. Just reassure her that it's okay. Like my mom, she's almost 96 years old. She swears everyone's a wuss. You want medication for menopause? She went through it with no problem. Of course, I say, listen, mom, everybody's not gonna be like you with no big problems. Some women can't handle the symptoms. Anyway, so if you can handle it, they say do nothing. If you got that's mild symptoms. Moderate symptoms, that means an occasional hot flash that actually soaks your blouse, kind of gets embarrassing. All right. I was surprised that this woman admitted to it because I knew about this literature. Acupuncture is better than medication. That's why Asian women don't take pills, they just do acupuncture. Acupuncture has gone head to head with medication. Acupuncture won. All right. I was surprised she put it in there, but she said it. Acupuncture is good if you can tolerate needles on your back, no problem. But Americans don't like needles in their back. So that's why the answer is SSRIs. Because anything that involves anxiety, because you're worried this is going to happen at work, serotonin, remember, helps you handle anxiety. So for moderate symptoms, SSRI is first line. It doesn't help you to hot flash. It helps you tolerate the anxiety of having a hot flash.
There's a drug out there called, it's basically marketed across the.
Right. It's used for hot flashes, yes, but it's the serotonin that takes away the anxiety of a hot flash. So now what you thought was a moderate symptoms is just mild to you now.
You're still gonna.
Oh, you're still gonna have a hot flash, but it's just gonna seem so mild to you, you don't even worry about it anymore. Yeah, that's how SSRIs work. They don't stop estrogen. Serotonin has nothing to do with estrogen. Yes. You mean, so some women having hot, if you're gonna have hot flashes, anytime something messes up your estrogen production, and then you suddenly go back to estrogen production. Yeah, that's something totally different. I don't know, whatever she has going on with her ovary, if it shuts down for a while and then comes back to working, you're gonna get a hot flash. But the physiology is still the same. Any sudden surge of estrogen, when the receptors are upregulated, you're gonna get a super normal response. Okay. All right, so that's why that's mild or moderate. Any questions so far? What about severe? This is when it's severe that she's actually taking days off from work because it's really affecting her job. You know, she doesn't want to lose her job. That's severe. Okay. For that one, you use estrogen replacement. Now, the studies on estrogen replacement, remember everybody ran away from it because the studies showed increased strokes and MIs. But when you look at the breakdown, it was a beta error. That means you thought there was no benefit, but there really was. When you look at the breakdown, the risk does not start till after 10 years. The estrogen replacement therapy has shown decreased mortality. You got 7 studies that showed it, that 10 years before menopause, decreased mortality. Up until 10 years after menopause, decreased mortality too. So that's why it was after 10 years, it was exactly 10.2 years, 10 years, 2 months. All of a sudden, wham, women are dying from hormones. That's why they said don't use it. But it means don't use it after 10 years. So anyway, so when you got severe, they say use hormonal therapy for up to like 7 years. That's just me. I stay 3 years away from the line. Okay, that way it doesn't happen to any of my patients. So I would use as replacement therapy for 7 years. By that time, over 90% are done with menopause anyway. So that's why I like that one. And you got 7 articles to back you up. Nobody's ever going to argue about that because it was well accepted in the medical community. So use estrogen replacement therapy for up to like 7 years. By that time, things are mild anyway. That means she goes back to the mild and maybe she can handle it. You don't need to worry about it anymore. Okay. But that's the current management of menopause in America. And then finally, osteoporosis. What the heck is osteoporosis? Osteoporosis at 9 is excess osteoclastic activity. Because over time, osteoblasts slow down their activity before the osteoclasts. So osteoclasts are still working hard, breaking down your bone, and you can't build it up fast enough. That's what osteoporosis is. It's loss of bone matrix. It is not a calcium vitamin D problem, folks. Even though we give calcium vitamin D supplements, don't pick that answer. I've seen it too many times, and they know some students are gonna be picking, calcium vitamin D is the problem. That's not it. Their calcium is normal, vitamin D levels are normal. That's not the issue. We give the calcium vitamin D supplements as just a part of helping to build more bone, but that's not the issue in osteoporosis. Okay. First line treatment for right now for osteoporosis is the bisphosphonates. How do you diagnose osteoporosis? You do a DEXA scan. A DEXA scan at any spot, because they do different areas, -1 to -2.5 equals osteopenia. That means you're not osteoporotic yet. So you just make sure she's doing normal activity, okay? Isometric and isotonic exercise, vitamin D and calcium supplements, just so she doesn't break down so much bone. So -1 to -2.5, osteopenia. It's just conservative management. Anytime it hits -2.5 at any site, you start bisphosphonates. And currently it's bisphosphonates 5 years on, 5 years off. Hopefully you still remember that from endocrine. We don't use it for, long periods anymore. Why? Because you get more fractures. Remember I told you about the 10-year mark, they saw more fractures. Why was that? Because now your bone has not turned over in 10 years. It cracks like a marble now. It's lost all its flexibility. If you want to use a drug consistently, that would be denosumab, the monoclonal antibody against the osteoclast. That one doesn't have to be stopped. All right, folks, let me make sure I got everything covered. All right, so here's that graph I showed you earlier. The first hump peak of estrogen, remember the graph, all 10 follicles. The next one is a surge from the graph in follicular cell. So estrogen controls the first 10 days. But look at LH, low till about day 8 or 9, boom, peaks. See that at day 14, and then boom, he's responsible for ovulation. And then after day 14, look who takes over. Progesterone takes over the whole second half. Okay. All right. OCPs, we've talked about it. Levonorgestrel is now the most common progesterone on the market. Okay. Norethindrone used to be number 1. Now he's number 2. Mestranol is the main estrogen on the market. Depo-Provera is progesterone only. It's an injection that lasts 3 months. Then we got 3 types of estrogen, E1, E2, E3. E1, look at that, 80% from adipose tissue, 20% from ovary. And then estradiol, 20% from adipose, 80% from ovary. This is just to show you why obesity is the biggest problem for precocious puberty for females. Let's see, what's the other? And heavy menstrual bleeding, dysmenorrhea, obesity, number 1 for all of them. All right, because that's unregulated. That's by aromatase and adipose cells. And your normal H2O axis is not controlling that. Estriol, remember I said 100% has to come through the placenta of a living baby. If the baby dies, estriol is the first one to drop off. Understand, Kathleen? Understand, Lauren? Cool. Hormone replacement therapy, I already went through for you. Okay. So these were the 3 benefits I just talked about: decreased symptoms of hot flash, decreased osteoporosis risk, decreased risk of coronary artery disease. All right. The controversy was it works for 10 years before menopause and for 10 years after. After that, it's more harmful than good. PCOS, we already talked about. Other hormonal drugs, I mentioned before, clomiphene is now the second most effective ovulatory drug because letrozole has taken over as number 1. Leuprolide is now number 3 for ovulation. And then RU486, remember, was a progesterone receptor antagonist. Is now an abortifacient, so it was just creating abortion. Any questions at all? And now introducing to you my main man, Tyrone. That's right, Tyrone, always stalking the female menstrual cycle. Yes, Lauren. Yeah. No, it's just that FSH comes out. He's talking about this, the line for FSH. FSH, notice, comes out to cause the estrogen to come out in the first 10 days. And then after he peaks right before day 14, he goes away because estrogen is not the one who controls the second half. Yeah, that's the way I would file that away in your head. All right. Let's talk about Tyrone, the male physiology. Because males are simple, Tyrone is simple. That's why I do it last. Look at that. We're spending like 3.5 hours talking about women. Men, maybe an hour. We're done. Okay. We're simple human beings, man. Yes. Sabu, you got a question? For the 3 forms of estrogen. Yeah, estradiol is the one that's most dominant throughout your young years. Estrone is the one that's most dominant after menopause because we all pack weight after menopause, and that's coming from adipose. So it makes sense. Somatogenesis begins at puberty. Austin begins at puberty. What is the first sign of puberty for a male? Look at that, testicular enlargement. Do we remember that? That's where the sperm is going to come from. You got to make room for them. So that makes sense. What's the first sign of puberty in a female? Austin? Breast buds, breast buds. When the testicles reach 4 centimeters, not 4 centimeters, 4 milliliters in size, you've hit menopause if you're a male. Did I say menopause? Yeah. Damn, okay. I've been talking about menopause for too long. Now I got menopause in my brain. No. It means you hit puberty. Sorry, not menopause. For a male, when the testicle is at least 4 centimeters in size, it means puberty has begun. Yeah, they do it in volume. Just measure the volume within the testicles. Yeah. I think it's 4 centimeters in size, not 4 cc's. 4 cc is not even a teaspoon. All right, all right, 4 centimeters. But anyway, it's a number I picked up on a few questions. They kept telling me the size of the testicles, and I didn't know there was a certain size that meant you've now entered puberty. I learned by missing it. Okay, so I'm just letting you know it so that next time you get the answer right. All right. So first sign of puberty for a male is controlled by testosterone. LH stimulates testosterone by stimulating the Leydig cells. Remember, Leydig cells produce testosterone, and testosterone does spermatogenesis. A lot of books don't tell you what FSH does in the male. In fact, a lot of students don't even know. That's because FSH stimulates Sertoli cells. Sertoli cells produce several hormones. Sertoli cells produce MIF in utero, Mullerian inhibiting factor. If you remember, MIF controls the internal half, the inner half of the internal male genitals, like I showed you before. The internal male genitals are divided into 2 halves, inner half, outer half. The inner half requires SRY gene from the Y chromosome. Okay. Let me see, testicle determining factor. They found a new one now, new hormone, TDF, from the testes, and then MIF from Sertoli cells. Yes, sir.
By the way, it is 4 centimeters squared.
4 centimeters? Oh, okay. That's what I said, 4 centimeters. Okay, yeah. Oh, okay. Yeah, it sounds like 4 ml. Centimeters is what I remember, but yeah, that's the right thing. But 4 milli sounds like too small. That's anyway, 4 centimeters is what most of them were right anyway. So anyway, Sertoli cells. That means to be a male, all right, to develop normal male structure. If you remember Sereno now, it's not new. I said for the inner half, I need a Y chromosome first. SRY gene got to be present on that Y chromosome. And then MIF has to be present. Then the inner half will become male. If not, it'll become female. That's how you become a true hermaphrodite. That means now the internal has both male and female structures inside. Okay? Sertoli cells, after you're born, produce inhibin. Because inhibin is supposed to feedback and inhibit FSH. So LH and FSH play a role in the male just like they do in the female, folks. They will ask you. Because I told you a lot of books leave out FSH function in the male, but they expect you should know it. All right? As spermatogenesis, now let's talk about that. Sertoli cells produce inhibin after you're born, produce MIF after, while you're in utero, okay, and maintain the blood testes barrier. Their job is to make sure that the immune system does not go into the testes. Why? The testes, the sperm that are in there are 1N. 1N. How many N's in a normal cell, Halima? Was that? Remember, 4 is only in a female ovary. That's the only time. It's 2N is the normal cell. So 1N is a stranger. Everybody understand that? That means if you let your lymphatics go in there, it'll destroy everything, and that man will be sterile. That's why we protect the blood testes barrier. Everybody understand? All right. The Sertoli cells also protect and nourish the sperm all the way to maturity. So let's look at some of the things that can go wrong. They can mess this up. And then you'll understand why we manage it the way we do. Number 1, hematoma from trauma. Usually accidental kick, playing soccer, football, baseball, whatever. You got a kick in the groin. Oh, me. If you want to hear a soprano, that's about the time. All right. That's why little boys wear protective cups. Protect the family jewels, right? So if you get an acute hematoma, listen carefully. You get an acute hematoma, I have to worry that that blood testis barrier also got splattered by that trauma. Does everybody understand what I just said? That's why all of them go to surgery. Because otherwise, doing surgery makes no sense to you because you don't know why we're doing surgery. It's because that little boy's gonna be sterile if we don't do something right away. So an acute hematoma, all right? That means he was playing baseball, baseball 89 miles an hour, it hit him there. Oh boy, he's gonna scream, but mom's gotta take him to ER and that kid's going to surgery. Because the urologist wants to know if that blood testis barrier is still intact. Because if it's not, it needs to be sewn up right away. Otherwise, that child will be sterile for the rest of his life. Because antibodies will come in there and destroy everything they see. Because those are strange looking cells with one N. That's not a normal cell. That's acute hematoma. What about if it's a chronic hematoma? Mom tells me, well, he's had this hematoma here for about 3 weeks. Oh, hell, well, he's sterile now. I got nothing to do with it. But you can't blame me for it. Okay. Then we say, oh, put some ice on it. Because if he's sterile, he's sterile. If he's not, then he's okay. So be careful. Acute versus chronic is managed completely differently. Okay. All right. Next one, hydrocele. Hydrocele is a collection of water. Seal is pocket, hydro water. Okay. Coming in from the abdomen through the inguinal canal, right? It usually follows the, what's that, tunica vaginalis? Okay. Same pathway and indirect inguinal hernia goes. And that's what they love to ask. What other complications you have to worry about? And indirect inguinal hernia can now develop too. Hydrocele, how do you know you have one? It transilluminates. You put a light behind it and it glows in the dark. What do you do about it? Nothing. Any questions on hydrocele? Next one, epididymitis versus varicocele. Epididymitis is an STI. That means chlamydia and gonorrhea. That means a NAT test will detect it, like we've already talked about. How do you know somebody has epididymitis? Number one, feels like a bag of worms, but it's at the top of the testicle. Varicocele feels like a bag of worms too, but it's at the bottom of the testicles. So location of the worms will tell you which one the diagnosis is. The other way to separate them, if you lift the testes, you take the tension off of the epididymis, it feels better. If you lift his testicles, he'll say, oh man, that feels so much better. That's epididymitis. What's the drug of choice these days on them? For gonorrhea. So ceftriaxone, and I'm going to put a company's name on it just so you know, they won't put Rocephin. Ceftriaxone, what dose? No, 500 now. They remember it used to be 250. 500 is because of resistance. Okay, so 500 milligrams one time. All right, and for chlamydia, remember they want doxycycline now. Yeah, it's too much azithromycin resistance popping up. So 100 milligrams twice a day for 7 days. NAT test will detect it for you. They want a test of cure 3 weeks afterwards. Now that it's so simple, most people will return and get it done because it takes 1 drop of urine. A test of cure 3 weeks afterwards. Now they say do another one 2 months later. Why? Because they tend to go back to that same old girlfriend or boyfriend and pick it up again. Just when you thought they broke up, no. They thought one more time. And then they spread it right back to each other again. Anyway, but they're right though. So anyway, that's why they say repeat it 2 to 3 months later. So that's epididymitis. Varicocele, varicose veins. We're all going to get it as we age. All right. If it's acute varicocele, that means your sperm is swimming around in venous blood. You understand that, Salon? You understand that, Montessori? Your sperm is swimming around in venous blood. Remember, varicose veins, that's venous blood. That means sterility is the big complication. So what do? Surgery. We're trying to prevent the male from becoming sterile. Okay, just so you know, why are we so aggressive? Well, for this one, if you don't do something, all the sperm are going to die. Then the blood testis barrier will break down because you're ischemic. That's acute varicocele. What about recurrent? Recurrent varicocele is the one they like to ask about the most. What you got to remember, gonadal vein on the right drains right into the IVC. Okay? They always make an anatomy question. Varicocele on the right, if it's recurrent, that means something's in the abdominal cavity, pressing it, going across it like this. And pancreatic cancer is #1 in older people. So that's why if they give you recurrent, you got to know, gee, what else do I have to rule out? Okay, on the right side, something's compressing the IVC, pancreatic cancer is #1. Well, you scan their abdomen to see what it is. And on the left, remember, left gonadal veins drain into the left renal veins, and then the IVC. So it's usually renal cell carcinoma. Either way, folks, it's something real bad. Both of those cancers have very bad prognosis. That's why you want to catch them as soon as you can. So recurrent varicocele on whichever side, folks, is a bad prognosis, but they'll ask you what you think is causing it. So it's different on each side. Any questions on that? Then the worst thing that can happen is torsion. What is torsion? When the testicle starts twisting around its blood supply and nerve, and then cuts it off. So the rule is this: any sudden testicular pain in any male equals torsion until you rule it out. Just remember that. Just like appendicitis, any right lower quadrant pain in a child, appendicitis is ruled out. So here's another one where the urologist will never blame you if you call him in at 2 a.m. Say, I think I got a guy here with torsion. All right, I'll be right in. He knows even if you're wrong, he doesn't get any ding on his record for being wrong, because that's the rule. Okay, sudden, severe, we go straight to the operating room. Just on clinical basis alone, you can take him. But there's 3 physical findings that tells me you have torsion. 3 physical findings. Now on the test, they don't have to give you all 3. That's all they do is give me 1, just 1. All right, number 1, the torus testicle rides higher, because remember it's spinning and going up like that. So no, they'll just describe one testicle rides higher than the other one. You got torsion. Number 2, the testicle that's torsing will lie transverse. Then the regular one lies vertical. You got torsion when I see that. And finally, if you lose your cremasteric reflex, if you stroke the inner thigh of any male, his scrotum always rises. This guy's won't rise. Because why? The pudendal nerve is trapped in there too. So the 3 best clues that somebody has torsion. But remember, you can take it to surgery based on clinical suspicion alone. Yes. For which one now? For torsion will be, yeah, the cremasteric reflex is gone. What is the Prince sign? What is it? Oh, yeah, just release, raising the testicle. Yeah. Right. Because what's the other one you're talking about? Epididymitis doesn't have that. Yeah. Epididymitis actually feels better when you raise his scrotum. Any questions on all these Sertoli cell problems? These are just testicular problems that could cause problems for Sertoli cells. Yes, sir. I don't think it's ileoinguinal. I thought it was pudendal. Yeah, it's pudendal nerve. Yeah. Ileoinguinal does a little higher up. All right, spermatogenesis for the male. 1 round of mitosis. Remember the female went from 2N to 4N. When did that happen, Chris? When did the female do that, Miguel? When did the female do that, Saba? It's in utero, 5 months gestation. Look at you guys have forgotten stuff already. I told you all that stuff happens early for a female. That's why she plans everything so early. 5 months gestation, mitosis already occurred. 2N goes to 4N. Primary spermatogonium for the male. We wait till puberty. We say, babe, don't worry about it. We got plenty of time. 14 years. Okay. Primary spermatogonium. Then we enter meiosis 1. 4N goes back to 2N. Secondary spermatocyte. And then meiosis 2. 2N goes to 1N. Tertiary spermatid. See? That's where the men get to have it. Just do it quick. Get it done. Tertiary spermatid. That means because men waited till the last minute, we do it quickly. Boom, 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 boom. Primary, secondary, tertiary, boom, ready to go. Okay. One spermatogonium gives rise to 64 spermatids. That's a lot of cellular divisions. As spermatogonium mature, they go from the basal layer, that's where you find immature sperm, to the top layer, that's where the mature sperm are found. Because I've seen pathology slide questions that say, oh, where would you find mature sperm in this picture? Well, if you say mature, it's got to be at the top. I mean, but it was a slice of the testes, just so you know. Anyway, immature sperm are down in the basal layers. Mature sperm are always at the top. That's because the epididymis, remember, is at the top. Once they mature, they jump into epididymis. Okay, and they will wait there until it's time to ejaculate. Each day, 20 to 40 million sperm mature. See that, Ashley? That's men. We like to overdo it. 20 to 40 million soldiers, man. This is war. It's a war, and we're going to win it. That's right. Uh-oh, wait a minute. 20 to 40 million sperm mature every day. Complete spermatogenesis takes 41 to 72 days. Sperm can live for 5 days in fallopian tube. Man, how long can your eggs live in the fallopian tube? 3 days. See that? Wimps. Wimps. 5 days. Yeah. Hey, but that's called bad planning. Why is it bad planning? It's because you're showing up to a party and they tell you there's gonna be women there. You find out there's no women at all. What are you gonna do now? Because if we show up 2 days later, the egg is dissolved already. There's no party. All of a sudden, hey man, hey Joe, any women over there? No. Hey Paul, any women over there? No, man. They told us women were gonna be here. Hey Tyrone, any women over there? No, man. Oh man, Luther Vandross is my song. It's my song. Hey Tyrone, you want to dance, man? And then they start dancing. You know what that's called? A molar pregnancy. You thought it was just a joke, didn't you? It's not. That's how you get a molar pregnancy. The egg was dead and the two sperm made contact with an empty sac. And so the two heads just fused together and now you have a molar pregnancy. That's exactly how it happens, folks. They say, two sperm, they tried to fuse with the egg was dead. So that's why they touched each other and boom, all of a sudden now they start dividing. But because you don't have mom's genes in there, it's uncontrolled cellular division. You got to have mom and dad genes to have control. You have no control. So how do I know you have a molar pregnancy? We have 3 clues. 3 clues. Mayha's counting them up already. You know one? Yeah. All right. First one, the beta HCG is supposed to double every 2 days. So if it's going higher than that, then that's how you know. That's 1. So that means they'll tell you the level you saw. Let's see, 2 days ago. Let's say it was 4. Today it should be 8. I'm just making up a number. But then they tell you it's 10,000. That's a molar pregnancy. You cannot go from 4 to 10,000 in 48 hours. Okay. So anytime the HCG is rising faster than you would predict, molar pregnancy. Number 2, fundal height. The fundus of the uterus is rising faster than usual. There's 2 landmarks, Halima, that they like to use. First one, the symphysis pubis, 12 weeks, 12 centimeters. Umbilicus, 20 weeks, 20 centimeters. So they'll give you a female and say she hasn't had a period in the last 4 weeks. You say, okay, she can only be 4 weeks pregnant. But then they say you can feel the fundus of the uterus at the symphysis pubis. That's a 12-week uterus. She can only be pregnant for 4 weeks. She got molar pregnancy. So they sneak it in there to see if you know what normal is. Folks, I told you, it's all about normal. If you don't know normal, you won't spot abnormal either. Michael. No, they're not that common, but they do occur. I don't know. It's like a couple of percent, maybe 1%. No, it's not even 1 to 3%. It's way less than 1%. Yes.
For fundal growth, if there's a discrepancy in there, you have to rule out incorrect dating birth.
Yeah, that's when they're just asking you what's the most common cause. The most common cause of let me see. Fundal height and beta HCG is always inaccurate dates, simply because teenagers couldn't tell you when they got pregnant. That's what happened. When a teenage pregnancy was going higher, they were telling the doctor the wrong date. That's because they truly could not remember. I mean, because teenagers sleep around so much now. I'm amazed. The girls are so sexually active. It's not even the guys. It's the girls are so sexually active. They can't remember who they were sleeping with when they got pregnant. And we're trying to help them figure out who the father is. It's like a damn Maury Povich show. You know, you're the father. Oh, no, you're not. Sorry about that. We don't know. Because she swears it's him, man. And then find out, nope, it's not him. Anyway, so inaccurate dates is the main problem now. But anyway, I'm just giving you what's going on here with molar pregnancy. All right, so it's 2 sperm that fuse with a dead egg and accidentally fuse together, and now you have unregulated cellular division. So the 3 ways to recognize it: fundal height is going too fast, HCG is doubling way too fast, or you got preeclampsia in the first trimester. Preeclampsia does not start till the late 2nd and 3rd trimester. That's when the baby outgrows his placenta and causes ischemia, which is what sets off preeclampsia. But if you got a molar pregnancy, the cells are dividing so fast that you get relative ischemia because they're sucking all the blood away from mom. See, still the same mechanism. But at least you know a baby in the first trimester cannot suck that much blood away from mom unless you got molar pregnancy. So those are 3 clues that makes you suspect molar pregnancy. Now, next thing I ask you, the carrier type. Most common carrier type, 46XX. Why? Because X's are stronger than Y's. Yes, women are stronger than men. I think men, we've conceded that already many times. Women are much stronger. So it's by chance alone. X chromosomes last longer than Y chromosomes. Question.
So the oocytes that are dead at end of day 3, is the cytoplasm still viable in that oocyte?
No. So if a oocyte is dead at day 3, the cytoplasm is also no good. That's why the sperm, when the 2 sperm came and fused with it, they actually went right through it and then curled with each other. Boom. And now you got an unregulated fertilization. But there's no living tissue. That egg is dissolving. Right? It's dying by apoptosis. All right. So metagenesis, folks. Molar pregnancy. Now, with molar pregnancy, number 1 complication is uterine invasion. This thing is dividing so fast, it eats right into the wall of the uterus. Number 2, even though it's a distant 2, is choriocarcinoma. That's the one every doctor is afraid of. Why? It's one of the most malignant cancers you'll ever see. Hospice care, they're dead in less than 6 months. They don't even last a couple of months. I mean, they die real fast. This thing divides so fast. All right, its favorite location for metastasis is your lungs. You get what they call cannonball metastasis. That means a bunch of circles, 10, 12 of them throughout the lungs. That means forget it. The person's at stage 4 already before you even know it. Okay. So number 1 complication again, uterine invasion. And number 2, choriocarcinoma. So how do we deal with this? We say, okay, we need to scrape this thing out. So what do? Scrape it out. Then you follow the HCG every week for at least 12 weeks. Because you want to prove the HCG goes back to normal and stays normal. Then you know you got it all. What if somewhere around 6 or 7 weeks, all of a sudden HCG starts rising again? Number 1, you got uterine invasion, or number 2, you got choriocarcinoma. One of the 2. Because it means all the tissue's not gone. Everybody understand me so far? So if the HCG comes down and stays normal, you stop. We're done. But if that HCG starts bouncing back up, you got uterine invasion or you got choriocarcinoma. That means both of those are rapidly dividing cells. What vitamin does all rapidly dividing cells need, Bailey? Folate. So that means we need to give them a drug that can block folate. Is there a chemo drug that can do that, Solange? Right? Methotrexate. See, that's how you talk yourself back into the therapy and management. Yeah, hit it with methotrexate right away. Wipe out the whole lining. That means if there's invasion, it's gone now. There's choriocarcinoma, you kill everything now. See that? And then you take HCG again for a few more weeks. Always talk it out, folks. That's how I remember these things. I'm always talking it out. Don't try to memorize it. And then that means you want the information to stand still. That's hard. Whereas if you start talking about it, what's the process going on? Your brain would then remember the connection back to the management and drug of choice or whatever it is they've been asking. Any questions on spermatogenesis? All right. Virility. Virility. There's a measure of virility. All right. 20 to 40 million sperm per cc of semen. 20 to 40 million sperm per cc of semen. You hear that, Ashley? 20 to 40 million. Wait a minute, we're not done yet. 4 to 5 cc's of semen per ejaculate. Wait a minute, do the math, bring out a calculator. 5. Oh, baby, 200 million. 200 million. Yes, Ben. It's a war. We come equipped with soldiers. We plan to win this war. But wait a minute. It's called bad planning again. Why? You're going to have to send in 200 million soldiers so that one guy gets a damn job. We got to sacrifice a whole lot of soldiers, man, so that one guy finally fuses with this egg. But it's a storm of troopers. Vroom, 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 vroom. They're coming. All right. No more than, 4 to 5 cc's per semen. No more than 40% abnormal forms. That means you only allow one predator willy in here. Why? Because he's eating all the damn food. How we gonna make that trip when one guy's eating up all the crackers? Hey, Predator, you in there? Come out, crackers falling out of his lips. Eh? Eat all the chips. Come on, man. And then Angelman's, well, man, that girl's cracking up at everything. Hey, girl, this is serious business. Stop all that laugh. I think she's smoking weed myself. Nobody's gonna believe me though. All right, so no more than 40% have no forms. And then look at this, 36% of the sperm must still be motile after 5 minutes on glass line. This is when if you go to fertility clinics, they put you in a cold room. Why? Because sperm don't like cold. All right, they need a certain temperature to live in. All right, but for the men, we always do sperm analysis first. Why? Because male factor, #1 cause of sterility. Now, the trick to the question is the woman who comes in complaining. Doc, we haven't been able to get a baby in 3 years now. We've been married for 3 years, no baby. Even though she's the one complaining, the problem is still male first. That's why we do the sperm analysis first. So anyway, they have you ejaculate on a slide, and then they put it underneath the microscope in that cold temperature to see if the sperm is still alive and well. So when she looks in there, see that shit, then she counts. No more than 40% are abnormal, good. 36, 30 to 60 are still motile. That means they're strong, strong. You see him, nice by a little garbage can fire, like that. Put some more paper in there, They got the hats on, they got the starter jacket on. Ooh, they got Wolverine boots. Yeah, they give you the thumbs up. Doc, ready for this? Yeah, ready to go off to war. But then they ask you, well, when are we going to war? Well, let's see. Look at this. The pH must be basic. Why is the pH got to be basic? Because we got to neutralize the enemy, so to speak. So remember, the female vagina is very acidic. When does she get her lactobacilli, Gloria? It's puberty. Remember, the vagina is very alkalotic till puberty. All of a sudden, these bacteria called lactobacilli show up. All right. And now colonize the entire vagina, producing lactic acid every day. And that's when the pH of the vagina then becomes 4.5 to 5.5. Okay. So for the male, you better be basic. Why? Because when you ejaculate inside and it's acidic, the sperm die on contact, unless you protect them. Basic. Any questions on that? All right.
Yeah, excuse me, sir.
Yes, maybe go ahead.
Please, the bacteria that lives in female private organ, is it normal flora?
Yes, normal flora.
Okay. So it doesn't kill, like it's not harmful, right?
No, it's not harmful. What's this
All right.
private organ called again?
I don't know.
Oh, Lord, I don't know. Good Lord, we still back in kindergarten? What are we gonna call it? Private organ? Call it vagina.
Okay, sir.
Okay.
I'm just asking to know because of some of the folks
Next
that
time, call it a vagina. I remember you guys are trying to be physicians. Don't play with these. What was it? We do it. What the hell is it? Don't talk like that in medicine. Don't say it. No. Name the parts the way it should be named.
Okay,
for some reason physicians are queasy about sexuality. I don't know why, but they are. Anyway, call it the right term. So
okay.
pH is basic to neutralize all this lactic acid. Now, why does the female need an acidic vagina? #1, to kill bacteria. Remember, the female urethra is short, so there's always bacteria colonizing her vagina. You better have lactic acid to kill all of them, and that happens. #2, to keep fungus in check. The female vagina, all mucosa, has fungus lining it. Well, as long as you're acidic, 4.5 to 5.5, fungus does not grow. Candida just lives there happily ever after. Doesn't bother you at all. But wait a minute. What if I give you broad spectrum antibiotics and kill them off? Why do you think they start getting UTIs? No, that makes sense. Why do they start getting Candida vaginitis? Oh, look at that. It makes sense all of a sudden. Just so how to remember those benefits. All right. Infertility. What is infertility? Infertility is inability to achieve pregnancy after minimum 12 months of unprotected intercourse. The key word, 12 months. So duration of time is very important, and it has to be unprotected intercourse. That means if you're using condoms, okay, well, that's understandable why you're not pregnant. Okay, if she's on birth control pills, okay, well, then we understand why you're not pregnant. So it's got to be unprotected intercourse. So if they've only been trying for 3 months, 4 months, the answer is see you back. Yeah, we're not going to start something mega workup for 4 months. Because I mean, some women become really anxious about it because they want to have a baby, because that time clock that women have in their head. All right, maybe society, unjustly does that to women. All right, so you got to try to understand. Now they're trying to bring it down to 6 months. I haven't seen it take over yet in the literature, so don't pick 6 months. I'm just letting you know why they're trying to bring it down to 6 months. Because today's women, women like to go chase their career before having babies. That means they're older when they try to have babies, and so we got so much infertility now, and that's why they thought, okay, we probably need to bring this down to 6 months. Anyway, infertility, 50% of male fact. That means it's the man's fault. Countries like my own, Nigeria, Asia, Middle East, it's always a woman's fault when they haven't had a baby. So my mom is like the oldest living elder in the village. She's like the godfather. Nothing happens in that village without Madame's permission. I just love watching her. And she just sits in there, little lazy boy. A line of women just line up, waiting to see Madame. Oh, Madame. Then they tell her their woes. If there's any kind of argument going on in the village, they bring the argument to her. She settles it. That's what the godfather does. And whatever she says, that's it. There's no more argument. It's law. Okay? And it's so funny, but I see a lot of women coming in, oh, Madame, he's going to be so mad at me. I haven't given him a child yet. Because the men want children before they drop dead. Men die young there. So they want a child as soon as possible. In fact, a man is allowed to marry another woman to have a child if the first one has not given them a child in 2-3 years. Now, this is America, that's Nigeria. That's totally different now. Don't start looking at me all strange. Okay? That's because the death rate is so high there. Just so you know, the man wants a son to carry his name on because he knows he's going to be dying soon, and he wants somebody who's going to carry that on. That's why they want a child and they want a son as quickly as possible. Well, the rule is you can marry as many women as you want, all right, to have as many boys as you want before you die. Now, my father was one of the first men to break from that tradition. He said one woman was enough. Smart man. I'm telling you, I don't know how guys can deal with two. One is enough. Trying to figure one out is hard. Trying to figure two out, you're going to get an aneurysm, man. So anyway, infertility is a male factor. Always do sperm analysis first, just so you know why that's the answer, even though she's the one complaining. Sperm analysis first. And they want 2 of them, at least 1 week apart, because men don't make the same amount of sperm every day. So I check it on this Tuesday, I check it next Tuesday. And this one may say 500 million, this one says 175 million. You average the 2, and that's the average that he puts out every day. Okay? Then that means he's good. Okay? All right, so always do sperm analysis first. 30% female factor, and the most common female factor is PID. And so what I see in so many books, most common cause of infertility is PID. Folks, that sentence has been wrong since it was written. And because test writers know students have read this in so many places, this is the first 8. That's the wrong answer, okay? They keep playing the same trick, and so many students keep falling for it. That's how they know where you got programmed, okay? What they really meant to say was the most common cause of infertility in women is PID. But I told you the book doesn't say that. They just said the most common cause of infertility is PID. No, male is number 1. Okay? All right. 20% is miscellaneous. And of the miscellaneous group, fallopian tube problems, number 1. This is why we do a histosalpingogram first. See, that's how I remember the management. I do my sperm analysis. If everything's good, histosalpingogram is next. I need to look at the fallopian tubes, look at the shape of the uterus and all that. That way you can see if there's fibroids, bicornuate uterus, see if there's anything anatomical going on. You'll see scar tissue from PID, okay? Any narrowing, so miscellaneous, fallopian tube is number 1. So now if everything goes well, look what happens. When the male ejaculates, the sperm go through the epididymis, head straight for the ejaculatory duct. Ejaculatory duct then joins the urethra about midway, and then the head of the penis over here to the right. So the sperm goes shooting out here to the right. It comes right here in the middle. Now, if you look over here on the left, you have a bladder. bladder has urine, pH 5 to 6. Remember, I just told you semen, it's got to have, you're talking about, we want the vagina to be 4.5 to 5.5. Even that's too acidic. That's the reason why if you let urine meet up with sperm, that's it. All the sperm are dead on contact. For that reason, folks, there is a valve here. Nobody's got their name on it, but there's a valve between ejaculatory duct and urethra. It has the longest absolute refractory period of all valves in your body. Why do you want that? That means when that valve comes down, all right, that means sperm can come out and come out and come out several times before you ever open up down here. And then after you ejaculate, then the valve goes up so slowly, which is why it takes time before you can urinate after you ejaculate. That valve does not go up quickly. And so the male, when he tries to go to the bathroom, has to sit there for a while because that valve is not going to open anytime soon, but you have to wait. That's because the physiology has it so that urine never meets sperm, ever, okay? Who controls this valve? Autonomic nervous system. What neurotransmitter controls autonomic nervous system, Melissa? Huh? Norepinephrine. So anytime you have autonomic dysfunction, this ain't working. What's the most common cause of that, Anam? Not ischemia, autonomic dysfunction. In an adult, Karis, diabetes is number one. So if you didn't know this, it would scare you when you saw the question and they tell you did a urinalysis and you can see sperm floating dead in the urine. See what they're trying to tell you? You would swear it's a misprint. That's for real. If you have autonomic dysfunction, you will see sperm dead in the urine of a diabetic. Parkinson's, usually 7 to 8 is dead. We're not worried about that, but Shy Drager has the same problem because that valve is no longer coordinated anymore. And so you can actually see sperm and urine meet up. And you see sperms floating dead because that pH is going to kill them. But the fact that you saw it in the urine, that's what scares a physician unless you know what it means. Yes, sir. Retrograde ejaculation, we're coming to that, I'll show you. All right, so this is normal ejaculation, so straightforward. All right, well, before sperm can leave, it's got to make 3 stops, Lauren. Number 1, stop at the seminal vesicles, you get semen and fructose. What's the semen for? Camouflage. Semen is camouflage. The sperm hide underneath the semen. Why? They wait till all that acidity of the vagina has been neutralized. Can't come out too early. Come out too early, you die. There's always that one sperm who wants to get a head start. I think I'm gonna get a head start. Tyrone says, man, don't go out there, man. Don't go out there. I'm saying, don't go out there. No, dude, man. Come on, man. There's one egg. I'm gonna get that egg first. Tyrone said, hey, man, I told you, man. I'm telling you, don't go out there. Bad things happen. You go out too soon. We'll wait till the bicarb neutralizes like that. No, man. I'll see you in the morning. And he goes out. Oh yeah. Well, guy, he wasn't quite dead yet. You got to fry him up some more. Anyway, any sperm that leaves too early will die on contact. You got to wait for the bicarb. See, that's number 2. Bicarb for the bubble urethral glands. Why fructose? Why we fructose? Why not glucose or galactose? Melissa knows why. Why would sperm pick fructose? Something you've learned will answer that question. No, not glue transporter. Let me ask. Nobody on this side has a hand up. Come on now, Bailey. It has no regulation. It burns fast. Sperm is moving real fast. So that means they need something that can burn real fast. That means burn faster than glucose and galactose. That's why sperm chose this. There's always got to be a reason, folks. You just got to think about it, okay? Bubble urethral glands, also known as Cowper's gland, produce bicarb to neutralize all the lactic acid in the vagina. Prostate, what do you pick up there? Zinc. Zinc is used in what they call capacitation reaction. Capacitation reaction. Capacitation is the act of removing semen off the top of sperm so that they can take off. Capacitation. Then you need acid phosphatase to eat through the cervical mucus. Remember, it's thick right now. And then you need hyaluronidase to eat through the corona radiata, which is really the granulosa cells around that egg. Hyaluronidase. Any questions? So the sperm must go through these 3 places before it finally goes out. All right, but if everything goes well, go right through your ejaculative duct and the head of penis. Let's shout over here on the right. Mabel, you have a question?
Yes, sir. Please, what did you say about acid phosphatase and the hyaluronidase?
I still think there's something wrong with that sound, boy. All right, so I just said acid phosphatase eats through the mucus, and hyaluronidase eats through the corona radiata, which is really the granulosa cells around the ovum. Remember, hyaluronic acid is just connective tissue. Mabel, did you hear that?
Yes, I heard it. I heard it.
Okay, all right, I want to make sure you heard me. All right, so now if everything goes well, boom. Stage of sexual response. Let me give you the story behind this. This started back in late 60s, early 70s. I came to America in 69, and this was just starting. It was called a sexual revolution. How did this revolution start? Well, they've done surveys of women, and I remember 29%, the article I reviewed anyway, said 29% said they've never had an orgasm in their lives. When you look at the breakdown, it was older women who were raised in this time, late 60s, early 70s. Women's consciousness started to awaken. They said, wait a minute. Men are the only ones who are supposed to be gratified by sex. This is for real, folks. If it helps you remember, this is why men said, I'm going to go get me some. Does that sound like you're sharing anything with anybody? No, because men were told sex was for you. Women were told by their mothers, sex is for him, not you. Your job is lay there, let him do what he's got to do. When he's done, go wash up. I'm serious. That's what these women were told. So they were never told how to enjoy sex at all. But then in the late 60s, women said, wait a minute, we want to enjoy sex too. This is not fair that we're just being used for sex. Well, then the question came, how do you enjoy sex? Well, women didn't know how to enjoy sex. So we had to teach them. So in order to teach them, you got to first learn what it is. A husband and wife psychology team, Masters and Johnson, did all the research on sexuality. They're the ones who came up with this. Masters and Johnson, husband and wife team. You know, the big thing back then, sex, drugs, rock and roll, woo-woo, all right? Okay, so what they do, I don't know if they rented or bought a house somewhere in the hills up in California, and they said, we'll let you use our house for the weekend. You can have sex all you want if you let us study you. Study you means we have cameras from every angle. We got sensors on your nipples. We got sensors on your testicles. We got sensors on your penis. We got wires hooked up your scrotum. We got wires hooked up to labia majora, intravaginal wall, cervix. With that many wires, I don't know how the hell you can even have sex, but they had it. Somebody worked it out. Today, that's called porno. But hey, now, back then, it was called research. Think about it. Cameras from every angle. Sounds like porn to me. But anyway, I give them credit because they did a lot of good research. All right, this is what helped women actually enjoy sex. Now, young women like you guys think, oh, it's a foregone conclusion. No, it was not back then. Women actually did not know what enjoying sex actually meant. They were always taught that it was for men, so they didn't know how to enjoy sex at all. Yes, sir. Masters of Sex TV show? So it's doing research about sexuality? Yeah, that was a big issue back then because women didn't know. So anyway, they're the ones who came up with all these phases. So let's go through them. First one, excitement phase. Excitement phase is exactly what it says. This is when you're getting sexually excited. For men, testosterone. For women, estrogen. But excitement is not the same thing as libido. Notice libido is not on here. Libido is the desire to have sex. For men, still testosterone. For women, progesterone. Wait a minute. This is why early on, for a female, she can enjoy the excitement of sex, but she doesn't have as much of libido as a man. Men are always complaining that my girlfriend doesn't have as much sex drive as I do. My wife doesn't have as much sex drive. That's because it's physiological, folks. She doesn't have the same drive. She enjoys it though. You just have to coax her into it. Okay, so Master Johnson addressed that too. So anyway, that's excitement phase. And they have a plateau phase. You're at the top of the mountain. And oh, what a beautiful sight it is. And there's trees, and there's meadows, and there's water. Woohoo! And then right before orgasmic phase, there's a sudden excitement phase. And then you slide down on the other side called orgasm or resolution phase and go wee. Okay. Everybody has the same phases, folks. It's just some are longer and one than others. And that's what we're gonna look at. What's the difference between men and women? It's different in each phase. But now, we said men, libido and excitement, testosterone. For women, excitement is estrogen, libido is progesterone. And that's because progesterone has a sequence of testosterone in it. So it's really testosterone for women too. Okay. Well, estrogen controls the first or second half of the menstrual cycle, Karina. Estrogen controls, controls the first or second half of your menstrual cycle. First half. Who controls the second half, Lillian? Progesterone. So that means a female has more libido before menses. Everybody understand what I just said? Okay. She can have excitement in the first half, but she doesn't have the libido. Okay. And so for a male, men have libido all the doggone time. So what happens as we get older, the woman has less estrogen. That means now more progesterone, more androgen. That means she has more libido. But at the same time, her husband or partner has less testosterone. Oh my goodness. So for the man, he has less libido and less excitement. At the same time, the woman is just finding libido with her excitement. Folks, this is a physiology of cougarism. That's how it happened. This is what I just like physio, sort of physio of cougarism. This is why older women started chasing younger men, because they knew at the time when they had the high sex drive that their husband had been wanting for so long, he can't keep up. So what do? Get yourself a younger man. And that's how it all started. They got their own website and everything. That's what I heard.
Really?
Research. Got to give a lecture. Got to research these things, man. So, oh my God, I tell you. Anyway, yeah, exactly. They even got their own reality show now. I saw that the other day. I said, oh my God. Okay. Yeah, cougarism everywhere now. But anyway, just so you know, there's physiology to cougarism. It wasn't just something somebody made up.
Sir, I want to ask something, sir.
Mabel, go ahead.
So maybe this may be the reason why some older men, because down there in Nigeria, you hear that older men with maybe for some maybe once in a time, or maybe I can say monthly, or you find out that some of those older men, they die on top of the younger girls, maybe trying to satisfy them or something. So does it have anything to do with a heart problem? Because they're trying to satisfy the younger ladies and they'll die on top of them.
Exactly. No, she's saying this happens in Nigeria. If a man tries marrying a young woman because he wants to have babies, but sometimes he ends up dying on top of his woman because he can't keep it with her desire, because he doesn't have as much testosterone as he thought he had, and then he drops dead right in the middle of intercourse. Yeah, it's not just Nigeria. This happens in a lot of countries. All right, but yeah, it's the same physiology, folks. All right, so these are the phases of sexual performance. Okay, so Masters and Johnson, they found out a lot of things. So after they got everything set up, let me just give you some summary of some of the things they found. Number one, women at that time, they polled women. They said, what do you think excites a man the most? And the most common answer was a naked woman. So women thought, if you just come out naked, that's what excites a man. It's okay, well, let's test it. So they had three groups of women. One, fully clothed women. Second, fully naked women. Third, the group was women just wearing their underwear. So, okay, let's try it out. All right. So they had probes, EEG, all kinds of probes around the skull, right? Fully clothed women came out and they took a look at the men, and the probe was going on 30 or 40 seconds and then stopped. Okay, they said, all right, bring out the naked women. And the naked women came out. Well, you hear about 30 or 40 seconds. That was it. Died out. And they brought in the half naked women just in their underwear. Probably still going on right now. If you go to California, you'll see it. That's when they realized men like the fantasy of sex. It's not a naked body that excites a man the most. It's the fantasy of sex that excites a man the most. So you know what they did? They tried to keep it a secret. And then too bad, somebody put it on the damn internet, man. And some lady named Victoria found it first. Now it's Victoria's Secret, boy. I'm telling you. But Victoria's a man. Just so nobody argues with me about that. That's just for the joke purpose. It's a man who figured this out. He said, wait a minute. That means I can start a lingerie industry in America. There was no lingerie industry in America until after this research came out, because he saw the opportunity. If men are more turned on by a half-dressed woman, I can make a fortune by just half-dressing women. And so they came out with lingerie, ta-da, which is a huge industry now in America. That was to satisfy the male. This is why in couples, if their love life is going stale, they always recommend like role playing. It's the fantasy of sex that excites a man the most. That's how you get him excited again. Okay. And dressing up in certain costumes and stuff. That's what excites a man the most. Not a naked body, like women thought. It's the fantasy of sex that excites a man the most. So they said, okay, let's look at sexual dysfunction. So now women knew how to excite men. What about sexual dysfunction? Okay. And then I'll do how to excite each side. Sexual dysfunction in young men, look at that, premature ejaculation. They call this performance anxiety. That's because if a young man is concentrating too much on what he's doing, he's going to feel anxiety. What's the first discharge from your brain if you're anxious, if you feel any anxiety? Oshni. Sympathetic or parasympathetic? She says parasympathetic. Parasympathetic, in erection. Remember point and shoot? He has a rigid erection. He's ready to have sex. He thinks I'm going to have sex all night. And then feels stressed, shoot. Sympathetic, he ejaculates, it's over with. Performance anxiety, they got that one perfectly, okay? I remember when my son was a teenager, listening to some of his friends talk one day, and I heard one of them talking about, yeah, man, if she's not saying, ooh, give me more after 5 minutes, that means you're not doing it right. I'm like, damn, man, you guys concentrating too hard on this. But that's what they thought. I said, that's exactly what Master John said. You guys are thinking too hard about it. The key is to relax and enjoy it. If you start thinking too much about the whole thing as a performance, then that's why you will feel anxiety. And that's why they ejaculate too fast. Okay. And then we call it premature ejaculation if you cannot hold an erection for at least a minute. Okay. Inside the vagina. So premature ejaculation was the main problem in young men. What about older men? So middle-aged men, stress-induced impotence. It was called climbing a corporate ladder. Well, if a man is stressed out about his job because his boss has got him doing three projects at the same time, he's stressed out. When he comes home, stresses out his wife. So it starts out with parasympathetic and the sex is still okay. All of a sudden you go into sympathetic and both of you are now impotent. She has no desire to have sex and he has no desire. He's impotent too. That's the stress. That's why they call it stress-induced impotence. The stress of climbing the corporate ladder, okay? What about elderly? It's called vascular impotence. Makes sense, atherosclerosis. Ischemia, remember an erection is engorgement with blood. Well, if you have plaques along the way, it cannot get engorged so fast anymore. That's why you get impotence. But look at this, folks. Atherosclerosis, decreased blood flow, makes sense to me. Takes longer to establish erection, makes sense as well. Harder to maintain erection, yep. Need for more direct stimulation? Yep. And then long refractory phase. Now, you see that part, need for more direct stimulation? Did you know that elderly people engage in more oral sex than young people? Now, it's hard enough for people to envision their mom and dad having sex. For some reason, that turns everybody off. Envisioning your mom and dad having sex, but they had to do something to get you, didn't they? All right, so I don't know why, but it turns a lot of people off to have that vision. Imagine grandma and grandpa getting in, oh, yeah, after midnight, that face come out at night. Face come out at night. That's grandma. Oh, you can't, you don't want that picture in your head. But grandma and grandpa be doing some freaky things, man. I had a 77-year-old man come into my office one time, and he had a indirect inguinal hernia, as big as a baseball. And I thought, oh my God, I probably have to fix this. And I started thumbing through his chart. He's had it for more than 20 years. I said, okay, I guess no rush. He's had it for more than 20 years. Ain't bothering him at all. So I just happened to ask him the question. I said, does that bother sexual performance for you? He said, "Psh, no. I said, why you say it like that? He said, Dr. Vance, come here. He said, at the nursing home, I got 2 girlfriends. He said, I get it at least 4 or 5 times a week, man. This don't pose no problem. Like, what? I was like, oh my God, man, come on. 4 or 5 times at age 77. More than most guys get, even in marriage or single. Man was so sexually active, and that didn't bother him at all. So my point is, folks, nowhere on here do you see libido goes away. It does not. Performance goes away, but libido stays there. Okay, they still have the desire to have sex, but performance just goes away. So then they just don't have sex. But don't pick an answer that says libido disappears with age. It doesn't. Okay. Yeah, they do. They have sex other ways. A lot of people, especially young people like yourselves, you guys think sex is only vaginal penetration. There's a lot more to sex than that. All right. The elderly people realize vaginal penetration when her vagina is dry. They say, no, we're not going to do that. Let's just engage in oral sex. All right. Mutual masturbation. They do that all the time. And they enjoy a very active sex life. That's my point. That means it's only if you ask, then they'll tell you. They had one study, and you know the elderly people said, I don't know why my doctors never asked me about my sex life. They were pissed because they said, why does the doctor think I'm dead? He never asked me about sex at all. Like I don't have sex anymore. This is somebody who was 80 years old, still sexually active. Okay, but the doctor never asked him. The doctor just assumed she wasn't having sex. That's when they realized the hang up is on the physician's side, it's not the patient's. It's the physician, like I keep telling you guys. Doctors have a hang up about sexuality. I don't know why. I always say, feel comfortable with your own sexuality so you can talk about somebody else's. Our job is not to judge people for their sexuality. Just listen, okay, and educate. That I see as a prime role of physician. We educate. I don't care what anybody's doing. My job is to educate them how to stay healthy and do what they like. Okay. All right. So elderly, remember that. And then let's see the difference. Yes. No, I said libido is not the problem. Libido doesn't decrease that much as you age. You still have the desires, performance that decreases the most. Okay. Mabel, you have another question?
Yes, sir. I want to know if there's any medication for premature ejaculation.
Sure there is. You learned it already. What was
I didn't-
it? You learned it already. Mitchell, tell her. Yeah, BSSRIs, which cause anorgasmia, the opposite.
BSSRI or
SSRIs cause anorgasmia, the opposite of premature ejaculation.
okay.
That's why SSRIs are used for.
I didn't know that could have saved someone though. Okay.
Yeah. So you can advise somebody to get treated if that's the problem for him. All right.
Okay. I could have treated my okay.
Okay.
My ex-boyfriend though.
Is that boyfriend now? Yeah. All right, folks. Now remember, try not to blurt out your business. I'll do the lecturing, so I'll do all the talking. Please don't let your business be known. All right, Pablo.
I'm joking.
Does propranolol work also for premature ejaculation since it's for performance anxiety?
No, the beta blockers actually just cause a lot more impotence. Yeah, so we don't use beta blockers. Yeah, but that's a good question. It doesn't work though. All right, so what's the difference between men and women? Here it is, folks. Men have a long refractory phase. That means it takes a lot longer for a man to get ready to have sex again, whereas women are ready to have sex at any time. Look at this. That's why women have a longer excitement phase. That's why, sorry, I think I said it the opposite. Men have a long refractory phase, but a short excitement phase. So because we have a short excitement phase, men are ready to have sex all the time. But women are not set up that way. Women have a longer excitement phase. That means they need more time to get excited. Then they can enjoy the sex, right? But they have a short refractory phase. This is why women can have multiple orgasms and literally just leave you out of the picture. Doesn't need you anymore. But that can happen. Women can have multiple orgasms, whereas a man cannot. So Master Johnson approached this as well. They said, what you need to do is understand what foreplay is. Do you know they're the ones who came up with foreplay? Foreplay was developed for the benefit of the females. Men don't need foreplay because men are ready to go all the time. But women need foreplay, what? Longer excitement phase to get them up that mountain. That's what it was about. So that's why men are then taught, you have to learn foreplay. It's not about you, it's about her. Because if you're always ready to go and you want her ready to go, but she's not, then there's going to be a battle. All right. Because some men are just so impatient. They're ready to have sex with no foreplay, no sensuality, no nothing. And the woman says, no, I don't want that. I want foreplay. I want sensuality. Men are much more sexual. Women are much more sensual. Right? That's why they say women are much more romantic than men. Because men start thinking, well, I don't need that. Yeah, you don't need it, but she does. So that means you have to learn how to play along. Okay? Because that way both sides get something out of this. Because if you're the only one, you climb that mountain. You get to the mountain, you go down the other side. You're talking about, wee. She's going to look at you and say, we what? What do you mean we? We, you. You're the only one who got something out of this. Now she's pissed off because she didn't get nothing out of it. You ejaculate way too fast. Okay? So you can say we, but she's not going to agree with that. So the sex differences. So, but if everything goes well, you're going through the ejaculatory duct till you get to shoot out through the right. Well, to address premature ejaculation, this is also on your exam. Squeeze technique. This is retrograde ejaculation that you were asking about. Master Johnson came up with this technique. You can teach it to anybody in less than 5 minutes. Okay? All you do is gently squeeze the head of the penis. Once you squeeze the head of the penis, it starts gentle peristalsis that goes backwards. That means the sperm will go right back to the ejaculatory duct all the way back to the epididymis. That means for that man now, he is charged and ready to penetrate again. That means he can hold on to that ejaculation until she's ready. Remember, a man climbs the mountain too fast. A woman needs time. Like the train that could. I think I can. Yeah, she's got to climb slowly. So that means for the man, you got to be patient. Men have to be taught patience. All right. So that's why we got places like there's a place in Chicago called Sybaris. If you don't want to, or you don't know what romance is, they'll do all the romance for you. You just pay a bunch of money. They give you your own room. In the middle of the floor, there's a jacuzzi. They put rose petals from the door all the way to the bed for you. That way, romantic. They got music going on, the way, and they got 2 masseuses that come in. You get a massage, she gets a massage. See, that way for the man, he needs to relax. Because remember, relaxation is what? Parasympathetic. That's called a point. That means a good erection. All right. She's relaxed. You're relaxed. Guess what? Good sex. You never have to leave the cottage. They take care of everything. You have a butler for the whole weekend. Now, this is what I heard happens in Chicago. See? It's worth the damn money, man. Come on, fellas. All right. So that means if you don't have any ideas of what romance is, let them do it for you. All right. The woman will be happy with you. Okay. Because it's a whole weekend of romance planned for you already. You don't have to think about anything. They do the whole thing for you. Okay. But this way, they make their money off of couples that have been married for a while. This is how to kind of re-energize your sex life. Okay. So that's why I fit in that protocol. So I said, cool, let's try it. All right. But that's why they take care of everything for you. And it jumpstarts your sex life again. Because after a while, you've had children, both of you are working. All of a sudden you guys are thinking about work all the time or thinking about the children all the time. And the sex disappears. And then people start getting real angry at each other. And that's why they tell you that's the time you slow down and do something like that. Anyway, squeeze technique. You can teach in less than 5 minutes. Squeeze the head of the penis, retrograde peristalsis. Sends the sperm right back, which means that guy can reinsert and keep going until she is ready. Once she's ready and she lets go, then you can let go. Okay? So squeeze technique, easy to teach. Now, the book says, so I got to tell you that, she used to squeeze the head of the penis. Let me show you why Master Johnson said that she should squeeze the head of the penis. Their whole theory was the cervix hangs down on an angle like this inside of her. When the head of the penis, when the man is ready to ejaculate, the head of his penis starts throbbing. That means the cervix will feel the head of his penis hitting it. And that's how she knows he's about to ejaculate. So she tells him, pull out. She squeezes the head of the penis, the sperm go back in, he can reinsert. That means he can hold on for an hour, 2 hours, whatever the hell she needs. That's what he's going to do. But again, You got to have a man who's patient because a lot of guys are not that patient. So here's what I do. For couples that have been married for less than 5 years, I already know he has no control. She should squeeze the head of the penis. After about 5 years, this is again my own experience, just working with couples. After about 5 years, the man becomes more in tune with his wife. He wants to make sure she enjoys sex now. In the beginning, he just wants to make sure he's getting sex. But after a while, he says he wants to make sure his wife is enjoying it too. So what does he do? A man can tell he's ready to ejaculate way before a female is ever going to feel anything. And that's because the muscles back here, way back here in the bladder, pelvic floor muscles, start contracting. They start throbbing before his penis starts throbbing against her cervix. So the man could actually stop this earlier. Well, when I went back to Master Johnson thinking, why didn't they ask the man to do this? They did ask the men to do it. The problem was the men enjoyed ejaculation so much, they never did it on time. So according to literature, they gave it to the more responsible gender, women. So anyway, just so you know, on your test, you're going to say, yeah, the woman should squeeze her head of the penis. But in real life, just modify it. Under 5 years, let her squeeze, but after 5 years, make him do it. Okay? That way it's his responsibility, and they will do it. Okay? And usually couples are so happy when you teach them something like this. I mean, just tell you my own experience with couples. They love it when you are a doctor who feels comfortable to discuss sexuality, because lack of sexual satisfaction, number 2 cause of divorce in America. This is not a small topic, folks. Just so you know why I separated it. All right. Otherwise, I could have just done it with endocrine and just skipped a whole lot of things. I said, no, there's too many questions on this stuff. I want you guys to hear the whole story from beginning to end. All right. So that's why we as doctors, the literature says doctors should get more involved, which means when you see somebody for their annual checkup or a couple for the annual checkup, you should bring that topic up. Okay. And you take the weight off of whoever has the problem, they take it off their shoulders. They're happy you brought it up. But all of a sudden, both of them will discuss with you. And let's say if the wife is the one dissatisfied because he has premature ejaculation or he's impotent. So now you bring it up the situation for young couples, it's premature ejaculation. So I say, most couples, about 95% of men your age. Now you guys been married how long? 3 years? Yeah. Most men, 95% have a problem with premature ejaculation. Nothing to be ashamed of, but it's a very common problem. You should see initially he starts out uncomfortable. So he hears me say 95% of men have the same problem you got. All of a sudden you say, what? All of a sudden he realizes all his friends are lying. That's what it does. It lets him up the hook because he thinks he's the only one with the problem. And most young men have the same problem. When you put a survey underneath the door and they start telling the truth, and yeah, they've had the problem, but they would never tell their friends that they had that problem. Okay. But once you bring it up, he feels okay because you said 95% of men. And guess what? The wife, you should see how relieved she feels that you brought up the topic because she's been dissatisfied, but she doesn't want to stress him out. Now, women are much more in tune with their husbands than vice versa. I'll give them credit for that. Okay. So the problem is she knows if she stresses him out, the problem gets worse. Everybody understand? Stress is the problem, right? So if you stress him out, guess what? It'll get worse. So that's why she just decides not to say anything. But at the whole time, both of them are dissatisfied with sex. They're not having enough of it, so the wife is dissatisfied. And the man is dissatisfied because he's stressed out because it's going to happen again if he tries to have sex with his wife. Okay? So something for us to help out in. All right. Premature. Yes. Oh, just a gentle squeeze for like 3 to 5 seconds. Yeah. All you got to do is squeeze the head of Mabel.
Sir.
Another ex-boyfriend problem here. She started cracking up now. Okay, what's your question?
Sir, please, I want you to demonstrate how to squeeze the head of the penis.
Oh, God. Mabel.
Yeah, we can save a soul or even save ourselves. You can never know.
I need a drink, man. She gonna drive me to drinking for sure. She gonna drive me to drinking, man. I'm trying to stick to Mountain Dew. You gonna have me drinking alcohol, Mabel? So I demonstrate the squeeze technique. Good Lord. I ain't got that much dedication to education, man. There are limits there. What Dr. Francis will do. All right, so anyway, squeeze technique. That's all you need to learn. Moving on. Once the sperm is deposited in the vagina, sperm hide underneath the semen. Remember, protect themselves from the acidosis. Okay? Bile covers then release to neutralize lactic acid. Zinc is then used for the capacitation reaction. Fructose is then clicked in for energy. All this is happening within seconds. And the sperm take off. Okay? 70% of sperm though are dead before they reach the cervix. 70%. So let's say there's 200 million. Oh my goodness. That means 140 million are dead before they ever reach the cervix. You know what the remaining do, Josh? You stop for a moment, break up in a 40 ounce. For the homies, you're gonna make the rest of this trip. Then you hear that song start playing. How do I say goodbye? But the light is up, but the light. But the homies ain't gonna make this trip. So all the sperm, they're dead. Sorry. And the rest are gonna go on without them. All right. So acid phosphatase, they used to eat through the cervical mucus. Remember, the cervical mucus is thick right now. You got to eat right through there. So here's oh, wait a minute. I think yeah, let me go through the rest of it first. Sperm then enter the uterus. Once they enter the uterus, they run into another problem. There's a fallopian tube on the left, fallopian tube on the right. And they're like, wait a minute, they didn't tell us there's 2 ways to go. And there's another half who will never see that egg because the egg is on one side. So they split up into 2 halves. Whoever picked the wrong side, you ain't gonna make it because you're gonna run out of fructose and there's no egg on that side. This half will see the egg. By the time they get to the egg, folks, there's only a few thousand left. Did you hear what I just said? From 200 million, only a few thousand ever reach that egg. That's just amazing. That's why they say if you don't have at least 200 million sperm per ejaculate, the chance you're going to fertilize the egg is less than 1%. It's not impossible, but it's not very possible either. Okay, less than 1% chance. 200 million. So that by the time they die out, okay, 3,000 reach that egg. But if you don't have at least 200 million, 3,000 is not going to get near that egg. All right. They swim through the fallopian tubes. By the time the sperm reaches the egg, only a few thousand are remaining. Sperm then surround the egg. So here's the ovum. Here's the corona radiata. Remember, radiant like the sun. This clear area in the middle is called zona pellucida, which really just means clear area. That's where the sperm heads are trying to get to. So here comes the sperm, they surround this egg. I'm just gonna draw a few of them like that. And what they do, they dart in and dart out. When they dart in, Miguel, they open up their sperm heads and release a bunch of enzymes to start eating away at this tissue. That's called acrosomal reaction. Sperm heads dart in, open up their heads, release a bunch of enzymes. Remember the acid phosphatase and hyaluronidase to eat through this tissue. And then they dart back out. They wait till there's actually an opening to get in there. Once an opening occurs, the sperm then come in here. So let's say here's the first sperm head to get in. As soon as he gets in here, a wall will form around him and that ovum. See that? Once that happens, that ovum then finishes meiosis 2. Remember, it's still stuck in metaphase of meiosis 2. She will finish meiosis 2, release the second polar body, and now fuse with that sperm. Now you have 46 XX or XY. Yep. And that's exactly where you want to be. All right. So the fact that a wall forms around the sperm heads and the ovum is called a crystallization reaction. All right. So you got capacitation reaction, peeling the semen off the sperm. That's before they even start moving. You got the acrosomal reaction, sperm heads release digestive enzymes to eat through the corona radiata. And then you got crystallization reaction, forming a wall around one sperm, one egg. Well, it's conceivable, Saba. It is conceivable that 2 sperm are running at the same speed. Just running at the same speed. That means slide in there at exactly the same moment. If they slide in at the same moment, guess what? A wall will form behind the 2 of them. Now you got 2 sperm fusing with 1 living egg. That's how you get an incomplete mole. Remember, complete mole was 2 sperm that fused with an egg that was dead. So there's no maternal genes to incorporate. An incomplete mole is 2 sperm that fused with a living egg at exactly the same moment. Again, rare, okay? But this one, what? Oh yeah, this one has maternal and paternal genes, which means that you can make a baby out of it. All right, 69XXY. Notice 3 sets. 69XXY is the most common. And notice again, 2 X's, 1 Y, because X's are stronger than Y's. Remember, 46XX was most common for complete mode. Now, if I got 3 sets of genes here, it doesn't mean everybody's going to be Klinefelters. That's what it sounds like, XXY. What'll happen is 1 X and a Y will slide over like that. Then you got a ball of molar tissue next to it. Or the 2 X's will slide over together. Now you got a girl, you got a ball of molar tissue next to her. But that only happens 1 to 3% of the time. Because anytime you mess up chromosomal count, remember, most times it dies. So you're not going to get normal babies. So what happens? That's only 3% of the time. The other 97% of the time, you get fetal parts, which is what Solange was saying. You get an arm, that's it. Look in there, there's a toe, and that's it. You look in there, there's an ear, and that's it. So anytime it's just fetal parts, you got to scrape it all out as quickly as you can. Remember, if just fetal parts, there's no wall. Mom is going to recognize there's these are in there, and she's going to attack the whole thing. If mom attacks the whole thing, what happens afterwards? She now has antibodies against herself because she killed the whole thing. This actually happens in a lot of women. How did we find out? With PCR, somebody spun. They took mom's blood and spun it, I don't know, 2 million, 3 million times. It's called cell-free DNA analysis. So it's PCR. By spinning it, they found 1 fetal cell at the bottom. And they said, oh my gosh, fetal cells do circulate through mom. We didn't know that. Very few, but they do. And that's why mom will attack it and make antibodies against herself. Everybody understand that? Years ago, I used to ask myself when they said every autoimmune disease is 8 to 10 times more common in women than men. And I said, why would it be that prevalent in women, not men? I said, it's got to be that mom is attacking who's over there. That's dad, and then she actually has to attack herself. But I could never prove it because no evidence ever showed fetal blood actually makes it over to mom, or fetal cells make it to mom till PCR came out. I said, I knew it. So I was so happy when I saw that. So now this is the earliest way to diagnose genetic disease in utero now. Remember, amniocentesis, 16 to 20 weeks. 5 months of worry? Nah, nobody uses that anymore. But CVS, chorionic villus sampling, you have to wait till 12 weeks. With cell-free DNA analysis, you can do as early as 10 weeks. And with that 1 cell, you can do all genetic testing that you want. Figure out every disease that baby has. So that's now the standard of care. Because no harm to the fetus, no potential harm to the baby at all. Just take mom's blood. Okay? All right. So a zygote is formed when 1 egg, 1 end, and the sperm, 1 end, fuse together. Now you have 2 ends, the beginning of a normal baby. The stages they want you to know. Zygote is a 2-cell stage. That's the first stage I just described for you. 90% of fertilization occur in the ampulla. That's a wide part of the fallopian tube. It must now migrate through the fallopian tubes all the way to uterus. So you can imagine, therefore, if there's any scar anywhere at all. See that? Ectopic. That's why 90% ectopics occur in the fallopian tube. Now you know why. So sudden adnexal pain in any female of childbearing age is ectopic or to rule otherwise. You got to move fast because that baby's going to burst that fallopian tube and bleed everywhere, and that might kill mom too. Morula is a 16-cell stage. It's a stage that enters the uterus. Blastula is the cell stage that implants. So that's why they want you to know these 3 stages. 256 to 512 cell stage is the stage that implants. So they'll ask you what to call it when they implant. So zygote when you fertilize, the morula when it enters the uterus, and then blastula when it implants. Now, from the time you fertilize the egg till the time it implants takes 7 to 8 days. Just a week. Well, that means, Maria, if you ovulate on day 16, let's say we're picking a number, and that egg can live 16, 17, day 18, right? 3 days. That means it gets fertilized, and then 7 or 8 days later, what are we up to? Day 24. That means in 4 more days, the lining will slough off, day 28. That means if they ask you, what is the first role or most important role of HCG? That's how you remember that. Keep that corpus luteum producing progesterone. Because if you don't, the lining will slough off and the baby will abort. That's what a spontaneous abortion is. So the number one role of HCG is to maintain the corpus luteum production of progesterone, to maintain that lining so that baby has blood supply, remember the coil arteries, and food, lipid and glycogen deposition until he establishes his own placenta.